Thank you so much for Urban Health Today for providing us this opportunity to talk about HIV disparities with this roundtable. Before we introduce our esteemed guest today, I do want to say a few words regarding HIV disparities. Current state of HIV in the United States remains a significant public health concern, and there have been incredible advancements in preventing and treating HIV that I'm sure we will talk about today. But there are still over 1 million people living with HIV. According to the CDC, approximately 38,000 people become newly infected every year in the United States, and this number has remained relatively stable over the past decade. But certain populations continue to be disproportionately affected by HIV. These populations include racial and ethnic minorities, specifically African Americans and the Hispanic Latinx individuals, who have higher rates of new HIV diagnoses compared to their white counterparts. Additionally, men who have sex with men account for a majority of new HIV diagnoses in the United States. Disparities also exist in terms of access to care and treatment for those living with HIV. People living in poverty or without health insurance are less likely to receive appropriate care and treatment, leading, unfortunately, to poor health outcomes. Furthermore, geographic disparities exist, with higher rates of HIV occurring in certain regions, such as the southeastern United States, which is where I'm coming to you from. These disparities highlight the need for continued efforts toward increasing education and awareness about HIV prevention and providing equitable access to healthcare services for all individuals. So with this brief intro, I do look forward to today's talk with our panel of HIV experts on disparities on HIV in the US and the barriers that continue to exist for testing and treatment. And despite progress being made, there's still much more work that needs to be done in addressing these issues and promoting equitable access to care for all individuals affected by HIV. And with that, let me please introduce our three panelists today. First up will be Dr. Monica Gandhi. She's an infectious diseases physician and professor of medicine and associate chief in the Division of HIV, Infectious Diseases, and Global Medicine at the UCSF School of Medicine. Dr. Sneha Jacob is an associate professor of medicine at Rutgers University, Robert Wood Johnson Medical School, as well as an HIV specialist with a background in internal medicine. And Dr. Hamadullah Shaik is an assistant professor in infectious diseases at Rutgers University, Robert Wood Johnson Medical School, and is associate chair for infection prevention at Robert Wood Johnson. Please, let's give our panelists a warm welcome. When we are talking about prevention, from your perspective, what are some of the challenges faced in promoting HIV prevention methods in some of these marginalized communities that we talked about? And how is it that your group, or even more on a general level, how can they be addressed?
This is such a great question, because obviously for prevention, at least in men who have sex with men, we have daily oral TDF-FTC, we have daily oral TAF-FTC, and we have on-demand TDF-FTC, which, despite not all governing bodies approving, we're definitely using, especially if, in a way, if sex is more unplanned. Because of that, and then we have intramuscular cabotegravir. And that has really helped. And so what's happened is that in California, at least, and I recognize that not all states have Medicaid expansion, but we are able to get the long-acting IM cabotegravir for every 8-week administration for HIV prevention, even for patient populations on Medicaid. And because of that, what we have noticed, and we've been doing this with long-acting treatment as well, what we have noticed is that when we rolled out TDF-FTC, the patient populations that were homeless, that had a backpack and that has their whole life in it, or live in a tent and can't really take that pill around with them every day, and they'll get stolen, and it is just sort of the least of your priorities to take a pill every day for HIV prevention when you're looking for subsistence and housing and food, and there may be substances involved. We just didn't see the prevention working that well in patient populations who had these structural barriers. And so what we're seeing now is with intramuscular cabotegravir, and we have been giving that out every 8 weeks in our patient populations, we are seeing that people come in to get it. And that's been really impressive. It's every 8 weeks, so it's 6 times a year. It's so much easier to prevent in that way. And that's why in the HB10 083 and 084 trials, IM cabotegravir was superior to TDF-FTC. It's just easier to get that shot every 8 weeks and then go about your day and have these other problems that we're trying to work on, and then taking the daily oral pill. So we have seen success with this in terms of HIV prevention. And I think that's the greatest advance. Lenacapavir is going to be, that we're going to get the results this year, 2024, from Purpose 1 and Purpose 2, which is in essentially cisgender women and MSM and other transgender populations, respectively. And I think that lenacapavir every 6 months is going to be a big deal if that works for prevention. And then one other thing I do want to say is that we've been thinking a lot about long-acting substance use treatments, long-acting Sublocade, for example, to pair with those long-acting preventative cabotegravir in those who use substances. That is just starting, but it seems like it really makes sense, because then you get kind of everything at once if the patient is willing to be treated for substance use.
That's great. Thank you so much for some amazing progress there. And I agree 100%. I think once we're able to get to some long-acting 6-month, 12-month situations, I think that globally, that's going to really be a significant game changer. And how do we get to an HIV-free globe? It'll be stuff like that where we can significantly either reduce the viral burden to as low as possible, or actually just try to eliminate it altogether by prevention. So really, thank you so much. Dr. Shaik, this next question is for you. You had mentioned pre-exposure prophylaxis. So just something regarding how does your clinic handle pre-exposure prophylaxis as we're talking about prevention? And how do you, who should consider taking it, and how is it that works within your clinic system?
Yeah, so our clinic, which is inside the Rutgers University, mainly deals with patients with private insurance, right? We are the number of patients who are uninsured. We have a very few number of them, because we have another branch of Rutgers where Dr. Jacob works, where we refer them the uninsured patients to them. When it comes to who should take or who should be on PrEP, essentially, anyone who has a risky sexual behavior should be, right? Anyone who has multiple sexual partners should be on it. Anyone who is, I know there is some data to support that it also prevents transmission in people who use drugs, should be on it. Now, with the IM cabotegravir, there is more and more interest in that particular drug, especially amongst our clinic patients. The problem has been in our clinic is the insurance approvals, right? It's been very, very difficult for us to get them approved based on their private insurance. And the main challenge for us, even today, I was working on a case to get IM cabotegravir for a patient, and the insurance there, the requirement was the patient should fail TDF-FTC or TEF-FTC. Now, if they fail, that means they have HIV. Why would I, give them the IM cabotegravir? So, things like that, and which don't make sense. It's like a catch-22 that we're in, that you have something which we can give, and the drug companies, they tell us, hey, listen, why don't you promote it? Why don't you give it? Why don't you tell your patients? And when we go down this rabbit hole of just getting the drug approved. Now, as I said, the uninsured population, most of it, we have another branch of Rutgers University, which is the Chandler Clinic, where they go to, where Dr. Jacob is. But we do have some uninsured patients where we can get the ADAP for them, which is, AIDS Drug Assistance Program. And surprisingly, that actually approves everything, right? That actually approves your IM cabotegravir, which is great, which is, it's like you're at a disadvantage if you have your own health insurance, which, it's been extremely challenging for us. But I think, slowly and gradually the landscape has changed. We have been able to get some patients on the IM cabotegravir, and we are trying to get some more on it. But in our clinic, when it comes to uptake of PrEP and the patients that we have and the new patients that we get into our clinic, I think the retention and the compliance is, I think, more than 95%, which is great.